I started practicing medicine with zero experience. I didn't have the luxury of touching a patient until I started working downtown. So I did some medicine at the hospital and then in the outpatient setting also. So medicine was very new to me as a PA. You all know as a nurse practitioner, at least you have that nursing background. So when I went into the hospital downtown, got very sick patients, and I would like, as much as I would have liked to have thought I was a rootin' tootin' cowgirl, I was not. I was very much a science nerd, and so I found a lot of comfort in that kind of background. So I loved guidelines. I love data. I love all of that stuff. And so rather than kind of rushing off to save the day, I would instead kind of hunker down and go through charts. And when I found something like, oh, an A1C was missing on this STEMI that we just had, or a diabetic isn't on an ACE or an ARB, it just rode right through me in all kinds of directions. So that kind of became my thing. And literally, I had a relatively young female, and I say that because I turned 50 in March. So a relatively young female come in with a STEMI, and when I did run an A1C on her, she had an A1C of 16, and she had no idea that she was a diabetic. And that will forever stand out to me. So it's important, it became very important to me to make sure that we started running A1C on all of our STEMIs and non-STEMIs. It became very important to me that I started doing Medicine 101, even though it was on the inpatient setting. And I got to where I really hated the inpatient versus outpatient vernacular, because guess what? We treat patients, not just inpatient or outpatients. So all of this kind of preventative medicine 101 things became really important to me. And I started to learn more and more about the interconnection between cardiovascular disease and all of these other conditions because they are very much interconnected. So we're learning more and more as this cardiometabolic revolution becomes vital in treating patients today. We're learning that it isn't just about cardiovascular disease or just diabetes, but there's this interplay between the kidneys, the heart, the endothelium that is in our arteries, and now we're learning more and more about the liver and the role that it plays. Adipose tissue, which that really came to light with the SELECT trial and the new indication for semaglutide. So all of this interplay now has really come to light with cardio-renal-metabolic syndrome. So as the importance of all of this interplay comes along, we're seeing more and more of these cardio-renal-metabolic centers kind of pop up across the nation. So there's a lot of different therapies to help patients reduce their cardiometabolic risk. I'm going to just go through these very quickly, unfortunately, because we do have limited time. There is a lot of different lifestyle therapies, and I do believe the importance of these. Diet is important. Increasing physical activity is extremely important. Alcohol, reducing alcohol intake. The value of no alcohol, we're finding out, is more and more important. Sleep is important. But I tell patients, I am going to treat you where you are today, and today you're still eating a cheeseburger. And so we're going to treat that LDL of 137 where it is right now, okay? So, but again, it still has value. So there was a study done not too long ago, and it looked at a high population, and you can see back in 2004, only 8.4% of Americans were considered having good cardiometabolic health, and that's looking at, did they have cardiovascular disease, did they have kidney disease, did they have a fatty liver, did they have hypertension, hyperlipidemia. That number we see has continued to drop and drop and drop, and I think most recently, 2018, now it's gone from 8.4% to 6.8% of American adults are cardiovascular or cardiometabolically healthy. So it just continues to decline and get worse. So we see that the biggest culprits is we have excess weight, and then we also have hyperglycemia, so high blood sugar. So The health disparities we see, social determinants of health, we're learning, obviously we've known this, right? But it's becoming more and more obvious that if you're non-white, if you're a man, if you're poor, and if you're lower educated, these do have a bigger impact on your health. Again, we've seen this in healthcare. We've known this, but now we have actual studies that support this. This is part of the reason why, personally, I love working downtown. You just have the ability to make a bigger impact on your patients, I believe. So just a bigger opportunity to make a bigger impact on patients. So when we look at different treatments to help patients reduce their cardiometabolic risk, I remember this when I went to school because, again, it wasn't that long ago. I've been practicing medicine a little shy of 6 years. This little pink chart was exactly what we used to study. And back in the day, metformin, it was all about metformin, metformin and, metformin and, metformin and. But this has drastically changed. It's not all about metformin and just treating diabetes. We're getting away from that old mindset, and we're learning that it's not about silos when we're treating patients, that it's more about an umbrella. We're treating the patient, the entire body, and where they are. So it's about treating the disease and the progression of the disease, because as, say, obesity progresses, as the patient has that adipose tissue that we've learned isn't just inactive fat, that fat is active and inflammatory, that inflammation leads to a lot of problems like kidney disease, like endothelial dysfunction. But we need to actually treat that whole disease as it progresses. So getting away from that, treating silos and treating the whole patient. The new patient-focused treatment, now metformin is no longer the star of the show. We no longer start treating A1Cs by starting with metformin. We can now treat with a GLP-1 at the beginning or an SGLT2. We're getting more about treating specific patients and the specific diseases that they have, which has been a big step. Also, it's no longer and or. We don't treat heart failure with a beta blocker and or an MRA and or an SGLT2, right? We're treating and until we get to those 4 pillars. Same thing with diabetes. We're treating with and, no longer and or. So that and or has been taken out of the guidelines. So that was a big step forward relatively recently in the treatment of diabetes. So what role do GLPs play in the treatment of patients with diabetes? We all know that they're going to bring A1Cs down, and they do a great job. You're going to get a 1.5 reduction in A1C. We all know that they're going to help patients lose weight, but what other benefits do GLP-1s bring to patients? They're going to help with their blood pressure. They're going to have anti-atherosclerotic effects, right? They're going to help protect the heart. They're going to help reduce heart failure hospitalizations. They reduce platelet aggregation. I tell patients the days are over where you take one pill and it treats one thing. Now patients, I tell them, when you take a GLP-1, it's a 1 in 2, 1 in 3, 1 in 4 kind of treatment. You're going to treat your diabetes, you're going to help your heart, you're going to help your kidney, you're going to help your liver. You're helping a lot of different things with just one injection, right? And, by the way, it does have a side effect. You're probably going to lose some weight. And I can almost always get a patient to agree to take, the GLP-1. So it has just a lot of different benefits. There's even other things. I mean, this isn't FDA approved yet, right? But they're even looking at how it helps with Alzheimer's. So there's just a lot of benefits to this drug class. This just goes over the renal benefits. This is why they are getting that CKD indication. The liver, this is the newest indication that they have right now for MASH. I didn't realize, as I look more into cardiometabolic syndrome, I didn't realize how many patients actually do have MASH. When you start looking in a patient chart, it's easy to find. If they have diabetes, honestly, odds are they do have MASH. If you go in and look at a CAT scan, incidental finding, hepatic steatosis, a fatty liver, look for the verbiage, it's going to be in there. And as you learn more and more about the importance of liver health, you'll see that we really do need to get more aggressive about treating hepatic steatosis. Of course, one of the treatments is just they need to be on a statin. And odds are if they have cardiovascular disease and they're going to be on a statin, but also the GLP-1 is going to help with the liver health. Calculating a FIB-4, I'm trying to get better at doing that on my patients on a daily basis. I'm not quite there yet, if I'm being honest, because there's a lot of other things I'm still calculating. But FIB-4 is on there with an elevated FIB-4, then that is going to be a referral to GI. I'm just not quite there yet, if I'm being honest with you, but that is a goal of mine. So we have the liver benefits of the GLP-1. Here's the current indications. There's just a lot of them on there. I know there's Trulicity. I just can't, if I'm being honest with you. These are the ones that I go to. I don't use Mounjaro as much just because they don't have the cardiovascular indication. I'm not as familiar with the dosing. I do feel like patients tolerate Mounjaro better, and you do get better weight loss. But for my patients that have known cardiovascular disease, again, I'm a data kind of gal. I'm going to go with Ozempic. If I feel like they have obesity-related heart failure, I'm going to lean more towards Mounjaro because I really do need them to lose that weight so they can also get improvement in their heart failure symptoms. But there's the indications. Like I said, the MASH is the newest indication. I do feel like we're going to see longer-term benefits in patients that get improvement in their MASH. Just years down the road. The sleep apnea thing, I don't know how I feel about that yet. It's an indication. If you need to get a patient that's obese, need to get a medicine covered, I'm all about finding ways to get medicines covered for patients. But again, I'm not still sure. Like, I think they have to have failed their CPAP or something. So that one's not one that I'm kind of using that indication a whole lot just yet. CKD, I'm all about that one. I love that indication though, because I really do think patients benefit from that one. SGLT2s, love the SGLT2s. We will start these in the hospital. Because if patients come in with HFpEF and their volume overloaded, I don't care if they have AKI, I'm still gonna slap on that SGLT2 because it does help get the volume off. So don't be afraid to put on an SGLT2. I personally feel like we have the best nephrologist downtown, and I listen to him all day long, and he's okay with it. And if he's okay with it, I'm okay with it because he's the expert. So we will put on an SGLT2 even if they have an AKI on their CKD. I realize that they will not maybe get the glucose lowering benefits if they have a lower GFR, but they're still going to get the benefits of that sodium getting out of there, which is going to pull off the water. So don't be afraid to leave on that SGLT2 with a low GFR, especially Jardiance, because they have that indication for heart failure no matter what the GFR is. Farxiga doesn't, but so I do tend to favor Jardiance a little bit more because the vast majority of my patients have advanced kidney disease. So again, don't be afraid to leave that on because a lot of times we're keeping patients on that for the heart failure benefit and to keep that, and that's HFpEF and HFrEF because we want to keep that volume off the patients. Reduced heart failure hospitalizations. Good grief, I talk about salt and peeing all day long. Let's see. Oh, you all, I wasn't sure if I was going to show these. This is me telling on cardiology a little bit. So, sorry, leadership. This was, so I wanted to talk about primary prevention looking at the cardiometabolic patient. So this is just showing the importance of controlling hypertension, hyperlipidemia, diabetes, and sleep apnea in a patient. So this doesn't have to be a cardiology patient. This is primary prevention. So this patient was referred to cardiology strictly for hypertension. And so saw cardiology to establish care, seen strictly for hypertension, and got seen and literally antihypertensive medications adjusted. Strong work. Then followed up with primary care, and this is a true story, not a Norton primary care, okay? And again, antihypertensive medications adjusted, okay? And then follow up with a cardiology APP. And then the cardiology APP followed up as a cardiometabolic patient. And so now the problem list went from just hypertension, and this is just looking at the chart, so it went from just hypertension to coronary atherosclerosis. That was probably just by looking at a CT somewhere. Hyperlipidemia with an LDL of 125. I get all kind of hurt about that. Just treat the lipids, people. Diabetes, Just look at an A1C, 8.3. Like, it drives me insane. It was not even, the patient didn't even know they were diabetic, had no idea. A1C of 8.3, hepatic steatosis, again, that was just by looking at a CAT scan, and the patient was obese. So all of that got added to the patient's chart simply by taking the time, and I know we're all limited on time, especially primary care. Also, Kentucky has like a 50% shortage on primary care providers, and I realize that. So changes made on that one visit. Aspirin got added just because they had coronary atherosclerosis. We added a statin to get that LDL down, also again because they had coronary atherosclerosis. Patient was educated, hey, guess what, you're diabetic. And we added Ozempic. So the Ozempic got added for the A1C, and also for the hepatic steatosis, and also for the obesity. So this could have all been done as a primary prevention cardiometabolic patient visit. So, and this doesn't need to be that all of this has to be done in a primary care setting. As cardiology, we can't put our heads down any longer and say, these medications are primary care medications and we're not gonna touch them. I don't treat diabetes, so I am not gonna check an A1C. I am not a primary care provider. I am not going to, I heard this so many times, I am not gonna treat hypoglycemia. GLP-1s don't cause hypoglycemia, right? So this was something that we had to battle with the cardiologist. So we can't say any longer that I am going to stay in my lane and I'm not going to treat kidney disease, I am not going to treat diabetes, I am only going to treat chest pain, or I'm only going to treat stents, or I'm only going to do this and that. We have to work together and treat the patient as a whole. And so part of what I like to do is really focus on getting cardiologists to open up and see that all of these things work together and create problems to the whole patient, including the heart, right? So working on primary prevention to hopefully prevent the secondary things. Although unfortunately, we're not getting them until we're now focusing on secondary prevention, which were some other slides, but I don't think I showed those. No, I hid those. And then by focusing on these metrics, what does these metrics mean to the patients? Leading cause of heart attacks is hypertension, and I can't tell you how many times I see patients in my clinic with blood pressures over 200. So uncontrolled blood pressure is the leading cause of heart attacks. Number 2 is uncontrolled cholesterol. So real quick, pearls for today. I challenge you, this is my biggest takeaway, I cannot stand uncontrolled hypertension, and I never cared about blood pressure, but I work downtown, and now it's probably my #1 pet peeve. I challenge you for a week, but at least for a day, check your own blood pressures manually. I love my MAs, but check your own blood pressures for a day. Because I had an MA and she's, oh, your blood pressure is almost, told my patient, blood pressure is a little bit low, 110 over whatever, right? Blood pressure was 230. And this happens all of the time, all day, every day, all day, every day. Check your blood pressures for a day. I promise you, you will be astonished at the blood pressure readings that you get. So please check your blood pressures and see, and educate your MAs on taking a proper blood pressure. Don't be afraid of PCSK9s, Repatha. Just do it. Just pull the trigger. They're fine. They're not scary. Patients love them. They're okay. Insulin. It's a growth factor. Just use the GLP-1s, use SGLT2s. I mean, my husband's on insulin. He's type 1, but, if we need it, we need it. But stay away from it if you can, and we definitely hate NSAIDs. Okay. Okay. Thank you.